A cannulated 6 mm drill is used over a guide pin to perforate the proximal humerus articular surface at its most superior aspect posterior to the bicipital groove. A 5 or 6 mm reamer is then used to initiate reaming of the humerus prior to broaching. If possible, it is recommended to continue with a 7 mm reamer, but reaming greater than 7 mm is rarely indicated in primary reverse procedures. The final reamer is left in place. The cutting block is attached to the reamer at the desired neck shaft angle for the proximal humerus osteotomy. Both a 135 and 155 degree cutting block are available in the Univers Revers instrument set. The block is held in place with 2 to 3 pins as needed. The third pin is an oblique pin, used if the lateral-most pin does not achieve adequate purchase. Alternatively, an anatomic-free hand cut may be used. The reamer is removed and the osteotomy completed. The surgeon may continue humeral preparation or place an appropriately sized protector over the osteotomy and proceed with glenoid preparation. The maximum base plate size that can be used correlates to the resection protector size, which covers the osteotomy site without covering cortical bone. The resection protectors are the same diameter in the respective cup diameters. A 2.8 mm pin is placed through the glenoid guide. The guide is placed relative to the inferior glenoid. The largest guide matching the glenoid articular surface is preferred, while keeping in mind that the size of the chosen glenosphere must match the size of the humeral cup. This ensures placing the glenoid base plate inferior and avoiding superior tilt. If a guide is used which does not cover the entire glenoid surface, the surgeon must evaluate pin placement and ensure the pin is not tilted superiorly. Central screw depth is determined from the pin markings at the drill guide surface and noted for use in subsequent steps. Glenoid preparation is accomplished with a primary and final reamer. If the glenoid surface has not been completely reamed, the correction post reamer should be utilized, followed by an additional use of the final reamer. The pin is removed and the base plate impacted. The 2 peripheral 4.5 mm locking and 1 central 6.5 mm locking screws are placed sequentially. Optimal stress distribution between the glenoid base plate and the glenoid subchondral bone is achieved by placing the inferior screw first, followed by the central screw and, lastly, the superior screw. The length of the 2 peripheral screws is taken from the cannulated drill guide. Remove the drill guide before removing the drill bit. This maintains bushing alignment and minimizes the risk of cross-threading the locking screw. Next, the 6.5 mm central screw tap is driven to the appropriate depth mark determined from the 2.8 mm guide pin in a previous step. The 6.5 mm central screw of corresponding length is then fully seated. The central screw depth gauge is used to verify the central screw is fully seated by visualizing a green color in the gauge window. If green is not present in the gauge window, the central screw needs to be advanced and rechecked until any amount of green is visualized in the window. The superior screw is placed last. The inferior and superior screws must be fully seated and flush with the base plate surface. In order to remove all tissue from the periphery of the base plate and glenosphere footprint, the coring reamer matching the base plate size is used first, and sequential reaming with larger coring reamer sizes is performed up to the corresponding glenosphere size. The coring reamer should be rotated both clockwise and counterclockwise to verify fully seated peripheral screws. If the coring reamer makes contact with a peripheral screw head, That peripheral screw must be advanced further until the reamer glides smoothly over both screws. Trial glenosphere are available if necessary. Unless humeral preparation was completed earlier, the proximal humerus is exposed and the protector removed. The canal is now sequentially broached to a good metaphyseal fit. The version alignment guide attaches to the broach handle. The final broach is left in place and the reamer guide pin is positioned. The reaming guide comes in a standard and 2 mm posterior offset for both the 135 and 155 degree configurations. The posterior offset guide option may be used to match the posterior medial offset of the proximal humerus relative to the shaft. The proximal humerus is then reamed to the appropriate size, 36, 39, or 42 millimeters. The appropriate reamer size corresponds to cut protector and cup size determined in a previous step. The reamer guide is removed and the appropriate inclination angle, size, and offset trial cup is linked to the impacted broach. A trial liner or trial spacer and liner may be inserted into the trial cup and the shoulder reduced. Range of motion and stability are assessed. If the shoulder lacks the desired stability with the trial liner alone, a trial spacer and liner are inserted together and the shoulder reduced. Based on intraoperative findings, at this point it is possible to trial the cup of the inclination angle not previously assessed. After the desired configuration is determined, the broach and all trials are removed. Next, the glenosphere is impacted. The Univers Revers instrument set has 3 types of glenosphere insertion options available, if needed. Here, the first option is demonstrated, and illustrations are provided for the other 2 options momentarily. To support ease of glenosphere removal, one of the glenosphere rim slots should be positioned directly anterior to allow the glenosphere removal instrument direct access through the deltopectoral approach. The glenosphere and baseplate Morse taper engagement must be verified with the glenosphere forceps before proceeding. Here, we illustrate the other 2 glenosphere insertion options. The humeral stem and cup are assembled and impacted. At this point, the trial spacer and trial liner can be inserted into the definitive cup for further range of motion and stability testing. A unique locking mechanism keeps the trials attached to the definitive cup during range of motion. If a required component, the spacer is linked to the cup. The polyliner is impacted and the shoulder reduced. Stability and range of motion are once again assessed.